All right, good morning, everyone. Thanks for having me here. We'll be going through the updated Surgeon's Guide to Non-Surgical Treatments for BPH today. Let me see if this is advancing here. So what we're going to briefly discuss today are updates in the literature for non-surgical approaches to BPH. We'll cover pharmaceuticals as well as complementary and alternative medicine, and then mention the relevance of integrative medicine to BPH care. So starting out with pharmaceuticals, we essentially have these three mainstays for management of voiding symptoms. We have alpha blockers, 5-alpha reductase inhibitors, and PD-5 inhibitors. So what are the updates in this space for each of these modalities? So first off, alpha blockers, we're all very familiar with these, and our updates in recent literature have centered around how to tailor medical management of persistent LUTs in patients who are already taking alpha blockers. Typically, the type of symptoms we're trying to treat here are frequency, urgency, storage symptoms, and typically the medications we're trying to add on in this domain are things like anticholinergics, or more recently, the beta-3 agonists like mirabegron and vibegron. So the recent study I want to highlight here is the COURAGE trial that was published this year. Over 1,000 men with BPH on alpha blockers already, with or without a 5-alpha reductase inhibitor, who had persistent symptoms of overactive bladder. They were placed on either daily vibegron versus a placebo for 24 weeks. And the study found that this entailed a significant improvement in IPSS, daily frequency, and urgency by week 12, which was maintained out to 24 weeks at the conclusion of the study. Notably, there were few adverse effects seen in this study. Less than 1% of either group developed urinary retention, and the rate of hypertension in the treatment group was the same as placebo. Moving on to 5-alpha reductase inhibitors. Again, we're all very familiar with this type of medication. It reduces circulating DHT levels. Recent study comparing 8 randomized controlled trials looking at dutasteride versus finasteride for 6 months looked at over 2,000 patients and concluded that dutasteride was slightly better at improving peak flow as compared to finasteride, but really no significant difference in any other parameter, including PSA, prostate volume, and notably no real difference in the rate of sexual adverse effects, which is often one of the reasons that patients don't like this therapy. And again, as we know, many men would want to discontinue their BPH therapy if it affected their sex life. And so we come to our last option here, pharmaceutical-wise, PD-5 inhibitors. Now we know that low-dose daily tadalafil is the only FDA-approved PD-5 inhibitor for LUTs, but there have been studies in the past showing that sildenafil itself can also be effective. So the update here is that 2023, it was a single-arm self-controlled study of just about 33 men. 6 weeks they were put on sildenafil, and after that a 4-week washout, and then 6 weeks of tadalafil. And the study authors found that sildenafil was more effective at reducing post-void residual as well as IPSS score. And finally, in this domain, I want to highlight also another study. This was a randomized controlled trial of just over 300 patients randomized either low-dose daily tadalafil or an alpha blocker or a combination of the two for 12 weeks. And the authors found the greatest change in peak flow, PVR reduction, and IPSS with combination therapy. And this one's important because it allowed us to update our prior guideline recommendation that previously said there may not be a benefit of combining low-dose daily tadalafil with an alpha blocker. And I think just anecdotally, we've all seen patients benefit from this combination. So is that everything that we have to offer non-surgically for patients with BPH? I would say no. There's actually rising patient interest in integrative medicine, which is a combination of mainstream medicine as well as evidence-based complementary therapies. And you might ask, who actually uses these types of therapies? Well, it's actually very popular. Over a third of Americans use these, and these can be things like nutraceuticals, yoga, hypnosis, and even traditional medicine. So we'll cover some updates in these fields just to round out our talk on pharmaceuticals here. So before I talk about nutraceuticals, I do want to say the studies are limited by short follow-up periods, variable dosing, and even batch-to-batch variation. Nevertheless, nutraceuticals are very popular amongst many patients, and the global market for herbal products in 2030 is expected to reach $160 billion USD. So a lot of patients are on these types of treatment approaches. We'll start off with saw palmetto. This is in virtually every men's health supplement, and there have been big trials in the past, notably 2006 and 2011, showing that even on a whopping dose of 960 milligrams a day, saw palmetto is really not that much more effective than placebo. The update here was a recent Cochrane review of over 4,500 men. They looked at 19 studies with saw palmetto alone compared to placebo, and then 9 studies with combination therapy versus a placebo. And again, there was little to no difference seen in avoiding symptoms or quality of life at short or long-term follow-up as compared to placebo. Next, I want to talk about turmeric. I see this a lot in supplements that people are on. This is thought to decrease the expression of the androgen receptor and be anti-inflammatory. Update here is a recent study, a double-blind, placebo-controlled trial of 52 men on either turmeric versus a placebo. Now, all of these men were already on an alpha blocker, and 40% of them were on finasteride and had been for over a year. And the authors found that at 3 months, the IPSS was improved by 3 points, and they also noted a mild reduction in inflammatory marker as well as oxidative stress levels. Moving on to stinging nettle. This is thought to be anti-proliferative and anti-inflammatory, but the clinical results, if you look at the literature, are quite conflicting. I don't think this recent study really clears that up, but for what it's worth, it was a study of men who were placed on 300 milligrams of nettle extract BID for 8 weeks, and the authors found that this improved frequency, urgency, and nocturia just slightly with treatment, but did not really affect any other parameter. Moving on to pumpkin seed oil. This is also a popular one lately. This is thought to inhibit testosterone-based prostate growth in animal models. In 2021, there was a single-blind randomized controlled trial of 73 men placed on pumpkin seed oil twice a day versus Flomax. And the authors found that at 3 months, they were both showing an improvement in IPSS. Tamsulosin was more effective, but notably, nobody complained of side effects with pumpkin seed oil. So that's it for nutraceuticals. What about mind-body treatments? So before I say anything about mind-body treatments, I do want to say that we already recommend these as first-line therapy for storage symptoms. And so what I'm talking about is biofeedback, avoidance of dietary triggers, fluid management, stress about urination. So we already do this. In this domain, there was a nice perspectives piece that came out earlier this year talking about yoga, and these are some of the poses that yoga practitioners will recommend for LUTs and how it might be helpful in the BPH domain because it has been helpful for some patients with prostate cancer and bladder pain, but more research is sorely needed here. Next, I want to talk about hypnosis. This is a mind-based treatment. Very interesting. This is a study of men and women with chronic pain and LUTs who underwent 8 weeks of hypnosis. And the hypnotic suggestions included things like better sleep, relaxation, and obtaining distance from your pain. And the authors actually found an improvement in LUTs and more severe symptoms correlating with a greater improvement. So this is something that was quite interesting that came out recently. And the last thing I want to mention is traditional medicine. So traditional medicine is actually now included in the ICD-11. If you scroll down all the way to modules 1 and 2, you'll find that they cover traditional Chinese medicine and Ayurvedic medicine. This is not supposed to be an endorsement of the scientific validity of any of these treatment styles, but it is supposed to help with recording and future research because of the number of patients who like to use these therapies all over the world. In terms of the data for traditional Chinese medicine, it really focuses on balance. These are some of the popular combinations for BPH, but essentially what I want to say here is that more research still is needed to establish the effect and the mechanism of action. Similarly, with Ayurveda, again, very much focused on balance of each person's elemental ratio. There are so many different herbal combinations. I won't even attempt to pronounce the one I have up here, but that's a popular one for BPH symptoms. But again, we still require rigorous studies to really describe the mechanism and the outcomes. Finally, I just want to wrap up this discussion by saying that pharmaceutical therapy remains the cornerstone of non-surgical BPH management. We know that alpha blocker and beta-3 agonist combination is safe for mixed LUTs, and it's effective with a low rate of retention seen with Vibegram in our recent study. Combination therapy with alpha blockers and low-dose PD-5 inhibitors also effective in recent studies as well. But patient interest in integrative medicine approaches is growing, and so as physicians, I think it's important to maintain at least awareness of the evidence-based complementary therapies and just consider this a natural extension of our discussion on biofeedback, diet, and stress as part of BPH care. Thank you.